and record right now. So we are recording for the talk.
Okay.
Thank you for reminding me.
Okay.
Yeah.
And after you finish it, you send me a file. All right. That's
absolutely.
Good. Right.
Yes. Thank you, Dai. Dai is keeping us on track.
Right. Let's start.
So, and for everyone, I'll pass it over now to Dr. Chand. And if you have questions as we go, as you guys all know, please feel free to jump in. And Dr. Chand is very nice, I promise. You can ask him questions as we go. If you would prefer, you're welcome to send a message in the chat and type one, and I will monitor that for Dr. Chand while he's giving his talk. And I'd be happy to ask the question for you as well. So with that, Jonathan, the floor is all yours.
Thank you. I'm going to share our chart here in just a second. Let's see.
I just opened the restrictions up, Jonathan, so let me know if it's not working.
Okay.
I'd be happy to make you, I'm going to make you a co-host right now just in case.
Okay. Is it coming up okay?
Yeah, we can see it looks great.
Okay. Hi everyone, again, I'm Jonathan with UC Davis here. We're just going to go over our evening lecture for today, which is on traumatic cardiac arrest. Before we kind of move forward, does anyone want to either share something that they know about traumatic cardiac arrest or have have seen any interesting cases at some of your hospitals before?
You know, Jonathan, maybe I'll jump in really quickly while everyone else getting settled, but we always have a really bad one in July, and we always have a new, so for Dai and all of our colleagues on here, we start new training, new interns in July. I feel like we always have one the first week of July, a traumatic cardiac arrest that is a disaster, and nobody knows what to do with it. And so a lot of times we have too many people in the room, everybody's trying to figure out what to do. And so we recently had a bad one where there was a young man who was thrown from a motorcycle, and it sounds like was actually found dead in the scene, but the medics started CPR and brought him into the emergency department. And so people really struggled with what to do next. So hopefully with your talk, we'll figure out what we should have done correctly.
So there are a couple of different kinds of traumatic cardiac arrest, right? So usually when we think about trauma, there's two two ways that we kind of think about it. We consider kind of blunt and penetrating. So blunt would be, it could be a number of things, like either, kind of like Shakira saying, thrown from a motorcycle or in a car accident or a fall. And for penetrating it usually tends to be more towards like assault type things where someone was like stabbed or injured or kind of something that like was injured by in a way that kind of breaks the skin. And when we have a traumatic cardiac arrest, usually that happens when, essentially the heart has stopped and CPR is being required. And the reason for that is because the patient had a traumatic injury to them. The survival rate is not the best for this condition, especially when they go into cardiac arrest, when their heart has stopped. And, kind of most research, most studies kind of place it at around, less than 10% where the patient kind of fully recovers with all of their, their thinking and their motor skills and everything still intact there. After a trauma, if the patient is in cardiac arrest, their heart is stopped. Usually, they're more likely to die or not recover well after about 10 minutes of CPR that's been going on. And kind of the goals that we want to do when we're considering, a traumatic cardiac arrest is really to kind of reverse it or intervene where we can, kind of before the patient has gone into arrest. So, whether they have difficulty breathing or they have a lot of pain or their blood pressure is starting to drop, those are all times when we want to kind of intervene as quickly as possible before their, the heart has completely stopped and they go into cardiac arrest. And at least from what I could see, MBCs are one of the leading causes of death for young people in Vietnam, but I'd love to hear from everyone else if you want to jump in and share about your own experience there as well, kind of before we go on, if anyone else has anything else to add.
Keep moving on. It's okay. In Vietnam, we have cardiac arrest with traumatic too, but most of them die.
Yeah, it's mostly motorcycles though, isn't it, Dai? You don't have as many car accidents, right?
Not many car, but the motorcycle is more severe because we just, when you have a motorcycle accident, you blow it away and you go to somewhere else. It's just like in the streets or stuck into another vehicle, something like that.
Yeah.
So we can move on. So this, I don't know, this is very specific to the US in terms of this context, but we can just go over and I'd love to hear about, your kind of how you approach, cardiac arrest as well. When we're taught about cardiac arrest in the US, we're taught what we call the H's and T's. And there's basically, these are what we call like reversible causes of cardiac arrest. So these are things that anytime someone comes in with cardiac arrest, whether it's based on trauma or an injury or based on a medical condition, these are all things that we're trained to think about in terms of things to reverse right away, or things that we can try to address in the ER. Has anyone ever heard of these, or is that I'd love to hear about how you approach cardiac arrest as well in Vietnam.
Yeah, I heard this before because they can get attention pneumothorax, the tamponade, hypertension, he can get sometimes some cases the toxis, not very rare in toxis in traumas, usually we get attention pneumothorax, and yes, cardiac arrest. It's just little about 10% can survive and have a good neurologic outcome. More than 90% they die if there's cardiac arrest. And if we cannot trace quickly, the reason can get the cardiac arrest.
Yeah, awesome. Those were pretty much the same things I was going to say. The reversible causes, are hypovolemia, either like from blood loss, hypoxia, where the oxygen level is dropping, hydrogen ion or acidosis of the blood, either a low or high potassium level, hypothermia, feeling really cold, or hypoglycemia, low blood sugar. And for the T's, like you mentioned, it would be cardiac tamponade, so kind of blood filling around the heart, any kind of toxin or poison, attention pneumothorax, or a blood clot, either in the heart or inside the lungs. So when we're, let's switch to the next one. So, out of all of those, the different agencies we just talked about, there's usually, there's a number of them that are kind of more common in terms of cardiac arrest in trauma patients compared to when we're looking at cardiac arrest in medical patients. And so some of those include like severe head trauma, for example, if you're riding a motorcycle and, you weren't wearing a helmet or something, you had an injury there. Hypovolemia from blood loss from an injury, to the belly or to the arms or to the legs. Tension pneumothorax, usually this comes with kind of broken ribs and an injury there. Pericardial tamponade, so kind of like an injury to the heart and where there's blood filling up around it and making it difficult for it to pump, or an airway obstruction, either an injury to the jaw or to the neck or to the face that can make it hard for the patient to breathe. And out of these kind of main topics, we're able to address about 4 of them as emergency physicians, as ER doctors here. Head trauma is a little bit more harder for us to address in the ER. Usually we need neurosurgery to be there. But blood loss, a pneumothorax, tamponade, and airway obstruction are all kind of things that are within our ability as emergency physicians to at least try to help the patient with. So kind of when patients kind of come in, a trauma patient comes in, at least here in the United States, we're trained with the ABCs of trauma. Is that something that you use in Vietnam as well?
And Jonathan, I would say, I think, I know we've gone through this together as a group, and these guys are very good at the ABCs, actually.
Okay.
And so without going into too much, I think they're pretty good at this part, actually.
Okay. So for the airway, airway would be the first one, any kind of airway obstruction, where there's an injury, to the face or to the jaw that can make it difficult to breathe for the patient. You do always want to remember, any kind of spinal cord injury that's going on, and make sure if you are going to intubate the patient that you do want to have another provider, another doctor, another nurse hold their C-spine to make sure, we don't further injure their spinal cord there. And as long as the patient, you're able to use a bag valve mask, the blue pumps, you're also able to give them oxygen that way. And if necessary, you would move on to a cripe, which is basically an airway inside the neck there. So, as with all kinds of trauma and ACLS patients, you do want to make sure the airway gets covered first. So this is our next case that we're going to go through. So we have a 57-year-old female who comes in the ER after falling down a few stairs while carrying a heavy box. She didn't faint or lose any consciousness. She was able to sit up, and her daughter brought her in the hospital. While in the waiting room, the patient starts having some difficulty breathing. So you go in and you examine your patient, and you see that the veins in her neck are bulging, and you don't hear any breath sounds to her left side. Her heart rate is beginning to go down, so we're kind of in the peri-arrest phase now. What are you considering is wrong with this patient, and how would you approach caring for her?
I guess he giving us attention to us because
right. So that's something that
we can guess need the decompression. We can guess chest tube. Need the decompression chest tube. Right.
Sorry, I just have a little difficulty here, but yes, we tension pneumothorax is definitely a very good thing on the differential. And we do, if we're concerned about her having decreased breath sound, that those are all, exam findings that are consistent with a tension pneumothorax. So how can so we hear breath sounds. Do we want to do anything else, or are we comfortable saying it's a tension pneumothorax? So what else? We can also, if you have X-ray available, you can also do that. Here's kind of a sample image of one where, you see the loss of lung markings on one side, and you see the heart completely pushed over to the other side, which exactly, like you said, was exactly right. We're worried about a tension pneumothorax. There are a couple ways we can kind of, try to figure out if a patient's having a tension pneumothorax or not. You can do it by auscultation, where you're listening to the lungs and you hear that some part of the lung is, you don't hear any breath sounds in some parts of the lung. You can use an ultrasound if you have that available to see if there's any kind of lung sliding. You can, on the ultrasound there. And you can do an X-ray where you see if part of the lung looks collapsed or the heart is shifted to one side. So the treatment for a tension pneumothorax, you can do a needle decompression where you would take a large needle, probably about a 14 gauge or so, and kind of insert it into the front part of the chest to help relieve, to basically let some of the air out where the pneumothorax is, or you can place in a chest tube as well. And both of those are ways that we can reverse the tension pneumothorax to hopefully prevent the patient from going into cardiac arrest there. And here's
Jonathan, I will say, as a quick aside, sorry to interrupt, these guys actually are getting really good at ultrasound and now have butterflies at their hospital. And so we're trying to work more and more on looking for B lines, or not B lines, looking for the actual lung slide on there as well. So that's a great option to jump to first. I don't know at Chorai or UMC, I think things happen quickly, but I know at the hospital I work at, it can sometimes be very challenging to get an X-ray there very quickly. And so we always teach the trainees that you don't want to see a tension pneumothorax on the X-ray. Hopefully you've diagnosed it before, but an ultrasound is a great way to do that quickly at the bedside. So thank you for including that, Jonathan. That was perfect.
Thank you. So this is a quick overview of how to kind of insert a chest tube. Essentially, you want to go to the 4th or 5th intercostal rib space, and you're going to make an incision and open up basically through the skin and through the fat layers and through the muscles into the pleural space. And then you're going to insert the tube here. You want to make sure you go above the rib here so you don't injure there's some vessels down here. You want to make sure you don't injure. You want to go right above there and then attach it to the rest of the machine there. And that will, that is hopefully, you know, one way we can help address the tension pneumothorax there and hopefully help the patient get a little bit better. Any questions so far before we move on to the next case? Good, okay, so our next case is we have a 21-year-old construction worker who was on a ladder when he slipped off and landed on his chest. So the ambulance brings him to your hospital. And as you're examining the patient, you do see some bruising and he has some tenderness and pain over his chest. When you listen with your stethoscope, you find it pretty difficult to hear his heart sounds. And his heart rate is starting to increase. And he says he's starting to feel faint and he might pass out soon. How would you care for this patient?
I think this is about the Tamponade, so maybe ultrasound.
Exactly, excellent. So, you know, one of the things we're really, the kind of immediate concern we hear is whether he has cardiac tamponade, right? He had injury to his chest, his heart rate's starting to go up, he's not, I guess, perfusing that well, he's starting to feel dizzy. So ultrasound is an excellent way to take a look. So this is what we see right here in ultrasound. What are we kind of concerned about here? Any ideas? So we have here with the right ventricle here, the descending aorta right here. What do we see right here in the pericardial area?
So Di put an option in the chat. If anybody wants to look in there, you're welcome to.
Effusion.
Exactly, an effusion, right? So the patient's a pericardial effusion. And, you know, this is, you know, kind of given his vital signs and his heart rate starting to go up because it can't pump out blood effectively. So it's trying the best it can, but it can't really do that. And he's starting to feel faint. So the pericardial effusion, it may be tamponading the heart there. And does anyone know what we do for a cardiac tamponade? We can do a pericardiocentesis. So this is, you know, you can, especially if you already ultrasound the heart, you can keep the ultrasound on the heart and look at the pocket of fluid you're going towards. You know, it's really nice that we have those tools now. And you want to insert the needle right under here, the subxiphoid area. And you can watch the needle go into the outer layer of the heart through the pericardial sac until it goes inside the fluid, and you can start draining it there. And even if you drain a very small amount, like maybe about like 50 milliliters or so, that can really help the heart beat a little bit better and hopefully, you know, at least prevent or help the patient improve if they're headed towards cardiac arrest. So like we talked about this one, cardiac tamponade, you can diagnose it with ultrasound or kind of hearing any like muffled heart sounds on your exam. The treatment here is pericardiocentesis. Let's go into the next lecture, next case here. Any questions on that one first before we move on?
Yes, I have a question.
Yes.
So do you use the needle 16 gauge or the needle 18? Which do you use, the type of the needle?
The type of the needle? It kind of depends on what you have. I have used anything from like an 18 gauge to like a small, like a 21 gauge. What is very important is that it's long enough, right? Because the heart is pretty deep inside. So it's not so much the size of the needle, but you want it to be long enough to go inside. So sometimes if you have spinal needles for like a lumbar puncture, I've used that before too. So you basically want the IV needles can be kind of smaller, usually about an inch or so. For this one, you probably want something at least probably 4 inches or so, and you want a syringe on the other end of it to help draw out the blood. So it's not so much the like, you know, I guess if you have a bigger size that works too, but you want to make sure it's long enough so that you're able to reach the fluid inside the heart.
Yeah, I got it. So the less matter and about the previous case about tension pneumothorax, which needle do you use?
So usually for the tension pneumothorax, I usually go for the bigger one, like the 14 gauge ones. And it's a little bit different there, right? Because for the pericardiocentesis, you're going underneath the sternum and trying to reach the heart. That's why it helps with the ultrasound there. For example, but if you're just looking at the tension pneumothorax, you can go basically the second or third intercostal space on the front part of the chest, the anterior part of the chest. And remember, if we look at here, the space between the skin and into the pleural space is not that big on the chest, right? When we're trying to let the air out. So you can take a regular 14 gauge needle, which may be about like 1 to 2 inches, one of the longer ones, and you can poke it in directly into the chest for a needle, if you want to do a needle decompression there.
I ask this because in some situations we just do it out at hospital. I mean, right at our hospital. So we don't have any tube. We just have needle. So I ask in case of that situation.
Oh, you do it out of hospital. I think especially if the patient is, the vital signs are starting to be unstable or they're not doing that well, kind of whatever you have, as long as it's clean and still, whatever you have to help reverse the tension pneumothorax works. So we want to make sure the patient doesn't go, doesn't get worse and goes towards cardiac arrest. So that's kind of our goal here. So if you're pre-hospital, I would say whatever you have is okay.
Thank you. So
I think those are great questions. Any other questions that we want to talk about first?
I have a question. Like in case like Dr. In said, in case of out of hospital, we don't have tools or ultrasounds or X-ray to make a exact diagnosis. So if we have misdiagnosed pneumothorax, tension pneumothorax, and we put the needle in the chest of the patient, but it turns out that it's not tension pneumothorax. So is it it can cause pneumothorax or not? Like it's.
Oh, I see your question.
Is it harmful to the patient?
Is it harmful to the patient? Shakira, do you want to jump? I'm curious from your experience.
Yeah, and this is really challenging, right? This is actually one of the reasons that we really want you guys to get comfortable with ultrasounds, because what you're describing is you're placed in the situation where it's very loud in the emergency department. It's very hard to rely on your exam. So you think that maybe you don't hear breath sounds on one side. And all of us want to confirm, even though the teaching is, if you don't hear breath sounds, you open that lung. We all are very nervous to do that. So I think part of what we're hoping is, in an ideal world, you'll be comfortable with ultrasound that you can look. If you don't have an ultrasound, the reality is you're going to do this on patients who are really sick, right? So for example, if your patient looks great, they feel really good, they're breathing comfortably, their vital signs are normal, it's unlikely to be a tension pneumothorax. So you might not hear breath sounds, but you'll have time to get an X-ray or a confirmatory image. If the case I can imagine is you have a patient who you don't hear breath sounds and they're actively getting sicker, they're getting hypotensive, maybe their heart rate is changing, or they're confused, I think it's actually the safest thing to go ahead and needle decompress that person and open up that chest. It is true. Let's say that's not what's causing it. The things on your differential at that point are tension pneumothorax, cardiac tamponade, and maybe actually even some other kind of traumatic injury. But if you're not hearing breath sounds, you're going to do each one in tandem until you figure out what's wrong. So I think if you don't have an image or ability to get an image, I would put the needle in the chest. It's very scary to do, but I think it's justified because you need to immediately decompress that lung. And Hannah, if you do it, what should happen is you decompress the lung and then you listen to breath sounds. If they're not getting better or you don't hear breath sounds, then you need to do something else. And so you're going to keep doing it. This is why, though, Dr. Chèn mentioned the ABCs, because it's so important that I think it's worth the risk of maybe overcalling it. And the reality is, if you put the needle in and you cause a pneumothorax, well, you've already fixed it. So it's okay, I think. So it's a great question and a very difficult situation to be in.
Thank you. Any other questions or any other things you want to talk about first before we move on?
I have another question.
Yeah.
Like in case of tension pneumothorax, is it need to use a pump like in Tamponade? The air just come out. I mean, in case of we put a needle inside, and is it the air it normally coming out? We need a pump to take it.
So my understanding is, and Shira, jump in as well, but my understanding is usually if it's tension and you either needle decompress, most of the air should come out because there's kind of like a one-way, usually there's a one-way valve into the lung, right, for a tension pneumothorax. If there's air coming in and it's not able to come out. And that's why we see the shifting of the heart on the x-ray right here. That's why we see it shifting over. Because there's air filling up over here, but it can't get back out. So when you put the needle, you're basically giving an outlet for the air to come out. So at least most of the air there should come out, at least so that the heart is hopefully a little more back in the center, and then there's not, kind of a tension physiology there going on. But either way, after you put the needle in, if they really did have a tension pneumothorax, I would still go ahead and put a regular chest tube in and connect it to suction, so that because they already have the pneumothorax and you're releasing the tension, but you do want the suction there to kind of suck the air out. But Dr. Banlin, or if you have anything else to add on there as well.
No, that's perfect. And in fact, I think, what you're going to do is the order of events will be you decompress that chest. Once they're breathing better, you're actually going to move on probably. You're going to go to circulation. You're going to finish your primary and secondary survey. Now you'll have time to actually put in a device that will create suction. While we were visiting, actually, I think it was Dr. Luck showed me that at Cho Rai, if they can't put in the chest tube, they actually have a system where they hook the decompression angiocath to a tube that actually hooks into water. So you can watch the bubbling happen. And so it was great to see because it's an example of how the air wants to go out, right? Because every time you breathe in, you're creating that negative pressure and then the air is coming out. So that's what's creating the tension pneumothorax. So to answer your question, you should just be able to decompress. And then when things calm down and things settle down, then you can put in a device that's hooked to suction.
What other questions do we want to talk about?
Yeah, these are great questions, you guys. Thank you for asking as we go. This is perfect.
Other questions we want to talk about before we move on? We're good. Okay. If we think about later. Oh, sorry. Do you want to go ahead?
I think it's good. Maybe UMC not do it frequently with trauma, but in general, everything you can do the chest tube, everything. So if you had a needle, just for a little bit time, for 5-10 minutes only. After that, the patient go to the dyspnea again, and in 5-10 minutes, you can put the chest tube very quickly on in, and you can suck it out, and everything is okay. So the chest tube is the best thing you can do. Needle is just a small one, just like if you don't have anything, you just do something like that. But if you have a granite like with the needle, it's not work for a long time. Yeah.
Actually, I just want to add in because usually this situation we need to do it right away at our hospital. So I want to ask about just the needle because in this situation, if we don't do it quickly, the patient will die maybe on the way to the hospital. Yeah. So I just want to do it quickly. But firstly, we have to make sure that the diagnosis is exactly. So and then we could do the next steps.
But yeah, if you need to do the needle first and hold off on the chest tube part, that's okay too, because the tension part is what's likely to cause a cardiac arrest coming up. So if you do that part and you don't have the supplies, you're not able to do the chest tube, at least you did the initial part to help the patient first. And then, depending when if there's other specialists coming in, they're able to get to the hospital, then we can consider doing, kind of some of the other things as well.
And Jonathan, I'll mention briefly, because I know this is a little bit different to where you guys practice, but we've actually taught our medics to do the decompression with the needle on the way into the hospital. By the time they get to see us, so sometimes people will come in and the paramedics or our team has actually put in a decompression needle already. Sometimes it's easier actually for us because we're so used to putting in chest tubes instead of doing the decompression. Like I think I've done, gosh, maybe like 20 or 30 chest tubes. I've only done like 1 or 2 needle decompressions. Mm-hmm. And so if you're in a situation where you feel more comfortable with the chest tube, it's now actually written within the trauma guidelines that you can do a needle thoracostomy, which is what Dr. Chand mentioned, where you do the first part of the chest tube where you literally open up the side of the chest with the scalpel and you put your finger in with some like metal object and it actually opens up there. And then you let the air out and then you pull out of the chest so that the skin actually creates a flap and closes back down, just like Dr. Chen's showing. And then when you have time, you go back in and you put the chest tube, but you can actually do a decompression that way too, without needing anything else. And that's actually now supported by the trauma guidelines as well. Yeah, thanks, Jonathan. That was perfect.
There's other questions that we want to talk about? Anything else we want to talk about before we move on? We're good? Okay. So our next case here, we have a 36-year-old male. He's wearing a seatbelt. He was involved in a 2-car crash on the highway 2 hours before coming to the hospital. He's coming in, he's saying he has worsening abdominal pain since the accident and has started to feel weak. You examine him and you see there's bruising and pain and tenderness all over his belly. His blood pressure is starting to drop, followed by his heart rate. How would you care for this patient?
I think that's a hard because the patient will be shocked. If the question is the patient can use the permissive hypotensive, permissive hypotensive. If he can get this, we can weigh a little and get the massive transfusion, use ultrasound and call the surgeon. But if the patient gets a severe shock, maybe near cardiac arrest, I will give him some vasopressors because he nearly to death, and I don't want he gets the cardiac arrest. So I will get him some vasopressors and massive transfusion and call very urgent for the surgeon.
Perfect. That's pretty much exactly, I think, what we would do here as well. What kind of, so like when the patient comes in and, the pressure's dropping and he has belly pain, what kind of ultrasound could we do to help take a look at that?
We can use EFAS.
Right, exactly, an EFAS exam. Exactly, an EFAS exam. So here, so this is a ultrasound. What do we see here?
Maybe a question, yeah, is it positive or negative, guys?
Positive.
It's positive, right? Exactly, right. And so yeah, exactly. We do exactly the same things that we just talked about in terms of we would want to if he needs massive transfusion, we would do that. We would call surgery to get involved because with free fluid in the belly, ultimately they need surgery for definitive care. And I'm sure you already know this, which is a review of a fast ultrasound, but the EFAS, we definitely look at the lungs up here as well. Yeah, so this also goes under C of our trauma evaluation for hypovolemia, low blood pressure, if you see active bleeding, blood on the floor, any kind of significant bruising of the chest or belly or extremities. If their legs or arms feel really cold or they're not having very good blood flow there, and we can, the best way to diagnose is with a fast exam. The treatment here is the master transfusion protocol, which here we use like a 1-to-1-to-1 ratio of red blood cells, FFP, the plasma, and platelets. Is that what you use in Vietnam as well, or do you have a different kind of master transfusion protocol?
I think if I remember right, John, just since I think it's actually exactly that. We learned that UMC also does it, and Chorai also does it. So they're very much on top of this.
So it's kind of standardized across the board here that we do a 1-to-1-to-1. Awesome. Some of the prognostic factors, with surviving a traumatic cardiac arrest, cardiac motion on ultrasound, and a shockable rhythm initially, the patient does go into cardiac arrest. Kind of the newest literature that I could find says that, like blunt versus penetrating is about the same. There used to be some, some people thought that penetrating was easier to survive than blunt, but now it looks like, the treatment is pretty similar for blunt or for penetrating trauma that goes into cardiac arrest. It's again, like these types of cases are very difficult to survive sometimes. So the current guidelines, at least here in the US, is really to follow your local hospital guidelines in terms of resuscitation. If there's an injury that's not really compatible with life, those are all reasons to stop the resuscitation. Or if when the ambulance or EMS arrives to see the patient and there's already no vital signs, there's no pulse there, those are in those cases usually most hospitals would not proceed with resuscitating the patient there. Just one more case here. So we have an 89-year-old, or any other questions before we jump onto our last case?
Yes. Well, I think that the survival rate is higher if the patient is coming to the operation room earlier, is right? And because if the main reason, the main point I want to say here is that when we use the ultrasound, we will find the bleeding. Is it inside the abdominal or inside the chest? So that we will ask the surgeon to come quickly and then move the patient right away to the operation room. Because of no matter how many blood we transfusion, but we don't find the reason that it's bleeding, and we can stop it. Is it right? So I didn't see that you mentioned operate quickly or not, and how and I think that we just need the ultrasound to find it, and then we move the patient to the operation room. We don't need any CT scan or any other diagnostic image. Is it right?
That's absolutely correct. You're absolutely correct there. Like if we see, if we ultrasound, we see some blood in the belly or in the chest, the patient's unstable, you don't need to go to CT scan. Especially with the patients bleeding, like you were saying, like you can give as much blood as you want, but if they're bleeding into the belly or bleeding in the chest, the blood's just going to keep going there and it's not going to circulate. So you're exactly right. Surgery is the kind of the definitive care is ultimately what we need to do. So if the patient is can go to the OR as soon as possible, that's always what's best for them.
Yeah. Okay. Thank you.
What other questions or things we want to discuss? Anything else? Okay. So our last case here, we have an 89-year-old man. He has dementia, high cholesterol, high blood pressure, and type 1 diabetes. And he's brought into the hospital after being found on the sidewalk about a mile from his home. He's tired and he's not really responding to you. And when your team examines him, you don't find any bruising or injuries, but he's pretty cool to touch. As he's being seen by your team, his heart rate goes down and he no longer has a pulse, and your team starts CPR. So, specific to this patient, what are some of the reversible causes that we want to consider and to think about for this patient?
The patient gets the hypovolemia because he got away from home and he very cold, very tough, and he has cardiac arrest, and this can be reversible, of course. Yeah.
Exactly right. So you know, we just want to make sure, you know, sometimes patients can come in like, you know, it seemed like they could have been a trauma. They, you know, they fell, or they, you know, they have some kind of a little bit of bruising, but we also want to make sure we don't forget about the medical causes, right? So for in this case, we want to think about, you know, he has, you know, diabetes. We want to make sure we check his blood sugar and make sure, you know, he's not hypoglycemic there or something. You know, he was found outside. We don't know how long he was on the sidewalk for, so we want to check his temperature and make sure he's not hypothermic. And we also want to do like an EKG or something, right? We want to make sure, you know, he didn't have like a heart attack that caused him to fall and cause his cardiac arrest. So this is just kind of a reminder that we want to make sure that we kind of consider other causes of cardiac arrest, even when we're looking at trauma patients, to make sure we don't miss anything. We're able to do everything we can for our patients. What other, we'll send out some of the references and some of the reading afterwards. But what other questions or things do we want to talk about?
That was great, Jonathan.
Thank you. Thank you, Shira. Anything else you want to jump in, or otherwise we'll kind of follow up with some with reading and everything as well, that you can look at your own time.
Yep, and for everyone for the rest of the month, so Jonathan, we'll send these out in email so you can take a look. This was kind of one of those things where it's such a big topic, and I think Dr. Chèn did a great job consolidating it. We'll send out the pre-readings and more readings as well for the rest of the month. We'll kind of do it a little bit ahead of time. Feel free, you know, I know Dr. Hui and Dr. Huan know this as well, but feel free to always send us messages, or you can always send Dr. Chèn or myself questions over email or WhatsApp, whatever you prefer. This is such a big topic and hard to cover in 1 hour. So reach out to us at any time with more thoughts, and we'll keep seeing you this month, and we can always field more questions as we go too.
That's so great, Shakira. So send us your PowerPoint, and
I will.
And invite Jonathan Chan to WhatsApp so he can chat with us.
Yes, we will. Yeah, Jonathan, we'll have to force you to join our WhatsApp group here, which I think Matt will add you to.
Yeah, sounds good.
Okay, good. And so everyone, we'll send out the Jonathan. We send the PowerPoints to everyone, and it'll have the readings attached. So you can go through there, and then Di, I'll send you this recording as well so that you can use